Anticoagulants. Coagulation cascade. Coagulation occurs due to the formation of insoluble fibrin from the fibrinogen soluble. This reaction is catalyzed by the enzyme thrombin. A series of coagulation cascades occurs where clotting factors are involved to form the coagulation. The coagulation does not occur in an intact blood vessel normally. The process of coagulation occurs following exposure to damaged endothelium. There are essentially two types of pathways for coagulation to occur: the extrinsic pathway and the intrinsic pathway. The clotting factors involved in any of these pathways are found in an inactive form in circulation. They undergo limited proteolysis into an activated protease. Consequently, each activated protease stimulates the activation of the next clotting factor in line, ultimately resulting in the formation of thrombin from prothrombin, factor 2. Thrombin is the central point in maintaining hemostasis. It cleaves soluble fibrinogen and causes polymerization of fibrinogen into an insoluble fibrin clot. Thrombin also activates platelets and other clotting factors and enhances clot formation. It also activates the protein C pathway, which decreases coagulation, hence maintaining the hemostasis. The extrinsic coagulation pathway occurs in the body and is initiated with the release of tissue factors. The tissue factor with factor 7A converts factor 10 to 10A, the first step. The prothrombin, 2, is converted to thrombin, 2A, in the presence of factors 10A, 5A, and calcium. Antithrombin 3 is a non-vitamin K-dependent protease produced by the liver. It inhibits coagulation by breaking down clotting factors 2A, 9A, 10A, 11A, and 12A. Important are 2A and 10A, thus helping in maintaining hemostasis by preventing abnormal clot formation. Here is a table showing various blood clotting factors and drugs that affect them. Factor 1, fibrinogen, there is no target. Factor 2, prothrombin, targets for the action of heparin, dabigatran, 2A, and warfarin synthesis. In Factor 3, tissue thromboplastin, Factor 4, calcium, and Factor 5, proaccellerin, there is no target. In Factor 7, proconvertin, targets for the action of warfarin synthesis. In Factor 8, anti-hemophilic factor, there is no target. In Factor 9, Christmas factor, plasma thromboplastin component, target for the action of warfarin synthesis. In Factor 10, Stewart-Prower factor, target for the action of heparin, rivaroxaban, apixaban, endoxaban, 10A, warfarin synthesis. In Factor 11, plasma thromboplastin antecedent, Factor 12, Hagman factor, Factor 13, fibrin stabilizing factor, there is no target. In protein CNS, target for the action of warfarin synthesis. And lastly, plasminogen, target for the action of thrombolytic enzymes and aminocaproic acid. Indirect thrombin inhibitors. These drugs indirectly act as anticoagulants by binding to the antithrombin 3 and enhancing the inactivation of factor 10A. Unfractionated heparins, low molecular weight heparin, enoxaparin, tinzaparin, and fondaparinux are examples of indirect thrombin inhibitors. Heparin, unfractionated heparins and low molecular weight heparin. Heparins are parenteral drugs which are rapid-acting and exert prompt anticoagulation action by interfering with the production of thrombi. They are strong acids due to the presence of the sulfate and carboxylic acid groups. In clinical use, low molecular weight heparin is more commonly used than unfractionated heparin. Low molecular weight heparin is produced from the unfractionated heparin by depolymerization of the molecule, chemical or enzymatic. Depolymerized heparins have some advantages over unfractionated heparin. They act by binding to antithrombin 3 and enhance the anticoagulation of antithrombin 3. The binding of heparin to antithrombin 3 causes conformational changes in the molecule and multiplies the rate of anticoagulation activity. In contrast to unfractionated heparin, low molecular weight heparin do not exert any action on the resting platelets, and also long chains in the unfractionated heparins facilitate binding of 2A to thrombin. This effect is not seen with low molecular weight heparin and fondaparinux. In this table, we see some properties of heparin and low molecular weight heparins. The intravenous half-life of heparin is 2 hours, and in low molecular weight heparins, it's 4 hours. The anticoagulant response is variable in heparin, whereas it's predictable in low molecular weight heparins. The bioavailability of heparin is 20%, whereas in low molecular weight heparins, it's 90%. Major adverse effect of heparin is frequent bleeding, whereas in low molecular weight heparins, there is less frequent bleeding. Setting for therapy in heparin is hospital, in low molecular weight heparins, both hospital and outpatient. Therapeutic uses of heparin. Low molecular weight heparin, more commonly, is used in the prevention and treatment of deep venous thrombosis, thrombotic diseases like pulmonary embolism, myocardial infarction, and prophylaxis in post-surgical cases, hip, other prolonged surgeries, to prevent complications which may arise due to thrombosis. It is also used as a prophylactic drug in the prevention of recurrence of coronary artery thrombosis in patients undergoing dialysis, and is safe to be used in pregnant women with heart conditions, history of prosthetic valves, deep venous thrombosis. The only clinical use where unfractionated heparin is preferred over low molecular weight heparin, fondaparinux, is for the prevention of catheter-induced thrombosis caused by factor 12 in cardiopulmonary bypass. Clinically useful heparins have a fast onset of action and are rapidly secreted out of the body on stoppage of the drug. The anticoagulant effect occurs within a few minutes of intravenously and within 1 to 2 hours after subcutaneous injection. Intravenous bolus is the preferred route of administration when immediate anticoagulation is needed, following which an infusion can be started as required. Unfractionated heparin is cleared by the reticuloendothelial system. Due to the unpredictable therapeutic effect of unfractionated heparin, activated partial thromboplastin clotting time (APTT) monitoring is done routinely, and levels are to be maintained higher than normal, 1.5 to 2 times. This is done to know the clinically stable therapeutic range of the drug for clinical effectiveness. Half-life of unfractionated heparin is around 1.5 hours due to rapid metabolism and conversion into inactive peptides, whereas that of low molecular weight heparin is around 3 to 7 hours. Half-life of fondaparinux, 17 to 21 hours, is greater than low molecular weight heparin. Both the active heparin and inactive peptides are excreted through the kidney. The plasma half-life of these drugs is increased in patients with renal insufficiency, so contraindicated in renal failure. Unfractionated heparin, low molecular weight heparin, and fondaparinux cannot cross placenta and hence are anticoagulants of choice in pregnancy. Side effects of heparin. Bleeding is the most common and life-threatening complication. Immediate stoppage of the drug or administration of protamine sulfate, protamine to heparin, 1 in 100 dosage, may be needed to counteract the bleeding. Hypersensitivity is another commonly reported complication that may present as chills, fever, hypotension, and shock. Heparin-induced thrombocytopenia, HIT. It's one of the important side effects seen in hospital-admitted patients. It's caused due to development of antibodies against heparin and platelet factor 4. The antibodies induce platelet aggregation and consumption, leading to a decrease in the number of platelets in the blood. It develops within 1 to 2 weeks after initial exposure and immediately in repeated exposure. It's a benign condition. Venous thrombosis is more common and usually developed in females. Treatment of HIT is immediate stoppage of heparin, and drug of choice for HIT is lepyridine. Other side effects include increased risk of thrombosis, decreased antithrombin 3 availability, resistance to heparin due to neutralization by body enzymes, hence decreasing the drug effectiveness, heparin-induced osteoporosis, alopecia, hyperkalemia, and abnormal liver function test. Contraindications. It's absolutely contraindicated in patients with a previous history of heparin hypersensitivity, bleeding disorders, recent surgery of the brain, spinal cord, or eyes. Oral anticoagulant, direct acting. Dabigatran etexylate is a direct thrombin inhibitor. It's orally active and is a prodrug for dabigatran. It's used in patients with atrial fibrillation for prevention of stroke and embolism. It has good efficacy and oral bioavailability and can be used as prophylactic therapy for the prevention of thrombosis and prolonged surgeries. Bleeding is the most common side effect. Other parenteral anticoagulants. Lepyridine. It's a direct thrombin inhibitor. It's developed from yeast cells by recombinant DNA technology. It has a one-on-one action on thrombin and prevents clot formation. It's administered intravenously and is effective in the management of heparin-induced thrombocytopenia and prevents other thromboembolic events. It's excreted by the kidney, and renal failure prolongs half-life, normal 1 hour. Bleeding is the most common complication. Regular monitorings of activated partial thromboplastin clotting time, APTT, and renal function test are essential while receiving therapy. Argadraban. It's another parenteral anticoagulant which directly inhibits thrombin. It's useful in patients undergoing percutaneous hemorrhagic intervention for the prevention of heparin-induced thrombocytopenia. It's safe to be used in renal failure patients, but caution is taken while giving in liver dysfunction. It's eliminated by the liver and has a half-life of less than 60 minutes. Major side effect is bleeding. Regular monitoring of blood counts, hemoglobin, hematocrit, and activated APTT is done to check the therapeutic efficiency. Coumarin anticoagulants, indirect thrombin inhibitors. They are the antagonists for the cofactor vitamin K, which is essential in the synthesis of clotting factors like factors 2, 7, 9, 10, protein C, and S. Examples are Warfarin, mainly used, and dicumarol, rarely used these days. International Normalized Ratio, INR, is to be regularly monitored when using vitamin K antagonist to prevent the complication of thrombosis, bleeding. International Normalized Ratio is to be maintained high above normal. INR ratio, 2 to 3 in most patients and 2.5 to 3.5 in prosthetic heart valve patients, and has to be checked regularly. INR above or below the following range can cause thrombosis if maintained below, or bleeding if it is above in the said range. Vitamin K plays an important role in the synthesis of the above said clotting factors. They undergo post-translation modification, where glutamic acid residues of the factors are carboxylated to form gamma-carboxyglutamic acid residues in the presence of vitamin K. This carboxylation reactions favor the formation of carboxylic acid, which is attached to the glutamic acid. This reaction requires carbon dioxide and vitamin K-dependent carboxylase. In this process, the vitamin K is reduced to form vitamin K epoxide. Generation of vitamin K requires vitamin K epoxide reductase. This enzyme is the target for the warfarin action. Thus, it inhibits the production of coagulation factors. Unlike heparin, warfarin is active orally, does not have rapid action, and may take up to 12 hours to show effectiveness. It's readily absorbed and is bound to plasma albumin, hence high bioavailability. It has a half-life of 40 hours, variable from patient to patient due to protein binding and CYP450 enzyme metabolism. They are metabolized by microsomal CYP450 enzymes in the liver into gluconic acid metabolites and excreted by kidneys and in stools. It's used after initial heparin therapy to prevent the worsening of disease and recurrence of acute deep vein thrombosis or pulmonary embolism. It's also favored for prophylaxis of acute myocardial infarction, thrombosis caused due to prosthetic heart valves, or following atrial fibrillation, or after prolonged surgeries. Side effects and contraindications of indirect thrombin inhibitors. Bleeding is the most common and dreaded complication of warfarin use, hence INR should be monitored regularly. An INR ratio greater than 4 leads to the causation of bleeding in most patients, hence caution should be taken to maintain it between 2 to 3, 2.5 to 3.5 in prosthetic valve patients, and the dose of the drug is adjusted accordingly. Minor bleeding can be treated with drug withdrawal. As bleeding increases, it should be reversed by intravenous therapy with vitamin K. If international normalized ratio, INR, is less than 5 and patient is asymptomatic, discontinue warfarin and resume once the INR is normal. If INR is greater than or equal to 5 and patient is asymptomatic, administer vitamin K. If INR is greater than 20 and patient is symptomatic, administer fresh frozen plasma. Other side effects include necrosis of the skin, especially in the breast tissue in females, decline in protein C synthesis, alopecia, and purple toe syndrome due to cholesterol emboli, bluish discoloration of toe. Warfarin readily crosses the placenta, but is avoided in pregnant patients. Warfarin is a Food and Drug Administration pregnancy Category X drug due to its teratogenicity. Warfarin causes congenital warfarin syndrome, which include hypoplastic nose, stippled epiphysis, and abnormal calcification of skeletal system. As it is metabolized by CYP450 enzyme, inducers and inhibitors of CYP450 alter the drug availability, effect, and toxicity. Disease conditions like hepatic impairment, hypothyroidism, hyperlipidemia, and hypermetabolic states have influence on the drug catabolism and its therapeutic effect. Drugs affecting the anticoagulant effect of warfarin. Acute alcohol intoxication, cimetidine, chloramphenicol, cotrimoxazole, disulfiram, and metronidazole cause inhibition of the metabolism of warfarin, which causes potentiation of anticoagulation. Chronic alcohol ingestion, barbiturates, glutathione, griseofulvin, rifampin, causes stimulation of metabolism of warfarin, which causes attenuation of anticoagulation.